thank you both so much for spending your time with us today. It's really important, I think, for the rare cancer community to know that at the highest level of cancer policy and research that rare is on the radar. And I don't think that would have always been the case, certainly not when Kate and Richard started RCA in 2012. It really is a new vernacular, a new landscape that we're living in. So thank you both for all of your commitment. Georgina, I have to ask the question that I think our rare community will be thinking when they listen to your incredibly bold and ambitious and personalised approach to the work that you've done, and that is what about me, I think would probably be the question, and how can people have care that is so holistic and so driven and so nuanced and out of the box? Maybe not tomorrow, but at some point, I feel everybody deserves a clinician that takes the approach that you've taken in your work. How can that be the case where personalised medicine is truly personalised and that clinicians have the time, space and knowledge to conduct that kind of care?
I actually think what you're doing, the moonshot, what David Thomas is doing with the genomics, the cancer plan that Dorothy's just outlined is actually trying to achieve that. It is a difficult thing, but it can be done. Having said that, the extraordinary amount of work that went into that one case it was difficult. Yep. But once you have a framework and once you have a thinking about it and once you have a pathway, then I think it then becomes the norm. So, okay, the other issue is with GBM, it did have a standard pathway. So it's not quite the same. It had a standard pathway. It was a randomized phase 3 trial published in 2005. So it was a bit different actually. But I think the approach that you're taking and the moonshot and this idea of every tumour needs to be interrogated molecularly and supporting that and then coming up with the drug therapies is really, really important. It's also important to do it scientifically because we do not know whether what I gave Richard has made a difference. Yep. We don't know in an individual what the natural history would be. He certainly was probably diagnosed earlier than usual. He was at higher elevation in the mountains in Poland and he'd just been on flights. So what I'm trying to say is one anecdote can set in train the concept, the idea of wanting to do it, but it is not evidence. Absolutely. And that's why the framework and what you're talking about today is so critical. And I think David Thomas was talking to me yesterday about the idea of the tumor mutation burden, microsatellite high tumor trial where people get immunotherapy, and it's those sorts of concepts. We've also got this great system in Australia, which is precious. I think I would have been put in jail in the Netherlands for what I did. But this precious concept that if you have a disease, not just cancer, that is terminal with a less than 12 months prognosis, we have a little bit of leeway, although expensive. You know, the rare cancer community knows that better than anybody because it's not on the PBS, so you have to access these treatments other ways. To think about other treatments, but it must be done scientifically. I cannot stress that enough because you will cause harm, and that is what the medical community, although we hear about slow issues, etc., they are afraid to cause harm because there is nothing worse than doing something out of the box that results in an earlier death. That is just that's a big burden. So the framework is perfect.
I think it's a really important and interesting conversation to have about the medical scientific standards, which of course nobody wants to compromise, but the people that just don't get the opportunities to have access to try something that they and their clinician believe is helpful or useful, or they just can't afford it. So I think it's a really important conversation. I'm very pleased to hear your perspective on it. Just quickly, you touched on clinical trials, and that is another real challenge for rare cancer community, given the tiny numbers. And of course, there's a lot of great thinking around molecularly designed trials, but randomised controlled trials don't work for rare. So what's
Pathway,
you being a clinical trial consultant?
Yeah, pathways are becoming more trodden or created. We've got to create these pathways for these rare cancers. It is very difficult. You're not going to get a randomised phase 3 unless you want to take 20 years or more. It's just crazy. So having pathways where you put a benchmark as what is evidence and accept that, and have the community and the scientific community and medical community accept that that is a good benchmark for this rare disease. And also starting to think of cancers in groups, so they're not just the histology, which is that whole idea of looking at tumour mutation burden, microsatellite instability, and other things that we're discovering, and thinking of those in groups and getting evidence that way is really important. But benchmarking, well, what are we going to take as evidence to support and fund this treatment? It's not going to be a randomised controlled trial. And just get practical. And being practical is not that difficult to do when you have the right conversations about it, and again, a framework that people agree with, and it's those conversations to get people over the line. I have to say that the treatment with Richard, it took a lot of conversations, not with the 5 people I showed, they were right there like that, but to get that support. And as a medico, do no harm is number one. And so you've got to get the support, not just from the patient consenting. I can tell you a cancer patient is vulnerable, and you have to remember that, and they'll consent to anything, but what if you trash their quality of life, shorten their life? No one's going to thank you for that. So you have to put some frameworks to protect the vulnerable as well, not in a paternalistic manner, but in a very open, transparent, practical way. And so I actually think you're doing that, and this is a wonderful forum to do it, to have this group, to have the cancer plan, and to be talking about it.
I love to hear you say, let's be practical. That's a real take home for me. I think that's absolutely right. We do need to be pragmatic. Dorothy, cancer control policy, our aspiration, 90% survival for 5-year survival for all cancers. Not even common cancers. Mostly common cancers have that outcome at the moment. What do you say about that incredibly aspirational vision?
Well, a couple of things. Firstly, nothing will change without ambition. So you have to have the ambition. Secondly, we have gone from a 5-year survival of 50% to a 5-year survival of 70% over the last 30 years. So change can happen, improvements can happen. And thirdly, if we just did the things we already know how to do for everybody, I think we'd see another 5 to 10% improvement. Just, my belief is if we implement the Australian Cancer Plan and we get care joined up and we collect the data, to your point about how you know whether something's working, you don't know if it's working in the 5 patients with this disease in the country unless you've got all the data and you can look back at it. So if we did those things alone, we would have some improvements. But then again, the next bit, it's actually quite difficult to implement the whole plan too, but the next difficult bit is to get all of the right work done. And, it's a challenge, but yes, absolutely vital.
Absolutely. I think we're all very much looking forward to an implemented genomic framework in the rare community for sure. But let me ask you about the data framework, and I understand there's already quite a bit of work that's been done there, but there are challenges, structural and cultural barriers to sharing data. I don't think Australia's unique, but there are many, many non-patient-centric reasons for people not to share their data. How are some of the challenges and opportunities that, as you see it in the cancer plan, how can they be addressed?
It's a very good question. I think the major way of doing it is by getting consensus in the entire sector that it needs to be done. So where you've got, I'm a great believer that if everyone agrees with each other, they're almost unstoppable. If you have divisions, anyone can drive a truck through. So what we need is cancer sector consensus, and that's what we're working to achieve. So that's why we have done a lot of consultation on the data framework while we've talked to the jurisdictions and why my team is on this jurisdictional tour now. You know, it's a hell of a thing to go all the way around Australia to meet with all the departments of health, but it's really important because their data people cannot say they have not been included in this, they haven't been listened to. And then, you know, there's a steering group, we've got all the players involved, and they are coming towards a consensus about what needs to be done. It is one of those, I mean, I'm not awfully fond of the expression, don't let perfect be the enemy of good, but this is one of the occasions where it's really important. Because, you know, just because you collect your data this way, and so collects it that way, if it's actually the same, reporting the same thing, there is a way that we can share and analyse. So the other thing I think is a role for the advocacy groups that, you know, one of the big arguments that the data custodians sometimes put forward is privacy. Well, yes, and it's very important, but as patients and patient advocates, and actually as the owners of the data, you know, I think sometimes people forget whose data it is. You have a voice here, and you know that voice can be used to, you know, pincer manoeuvres. I find are very useful. So if we've got consensus on one side and we've got advocacy on the other side, I think we'll get further. So, you know, it's not easy, but we're not giving up, because how can we tell how we're doing if we don't have the data?
Absolutely. And I think I can imagine Richard reviving his "Who Owns Your DNA" speech sometime very soon.
I look forward to it.
To both of you, people living rurally and remote have per kilometre worse outcomes. We've got the data on that. When you add into that a rare or difficult to treat cancer, whether it's common or it's rare and unknown, outcomes are poorer. Now, the Comprehensive Cancer Network goes some way, I think, certainly philosophically, to fixing that. But I think if you were in a very rural or remote town and you had one of these difficult to treat cancers, this would seem like a real blue sky, pie in the sky. I mean, can people living in Broome with a rare cancer expect to have world-class cancer care quickly and equitably in 10 years?
Yeah, well, if not, I will have failed. You know, that's the job, is to get that happening.
Yep.
And we didn't talk about the navigation system in here, but you all know about the nursing and navigation system. The navigation system of the plan is that anyone who has a cancer is then linked into the support they need through the websites, the apps, escalate if you're not getting it to a phone line, escalate if that doesn't work to a nurse, and you know, and quite often a nurse that you need to see on the way too. But the idea is that you get into that system and all of the things that you need are available.
Yeah.
Now, it's a big job.
I've just got 3 comments to make on some of the topics just then. Number 1, 5 to 10% improvement in overall survival, implementing basic things that we already have. I actually think we could also accrue additional 20 to 25% if we had the right clinical trials and explored current things like immunotherapy better, much better.
Yes.
The ones that are available and have been developed now for 10 years. There's no doubt about that. And there's a whole education piece on that.
Yes.
And then the data thing, the privacy issue is big, a big barrier, massive barrier. But also on the other side, we have to then create reassurances for patients about their data being secure. And so having that piece just as prominent and talked about gives a lot of confidence, so advocates can say, yes, we want our data. And then the last one was about distance. We did a study within MIA, and we saw no difference in outcomes for our regional patients who are treated with us, and we have the same rate of clinical trial participation, which is 50%. And the key is advanced care nursing, and that is nurses who are operating at a very high level. It's not about hand-holding, about the anxieties and traumas, we get that, right? But the advanced care, nurses are professionals with good training. They need to be slotted into advanced care. And that will protect patients, that will enable them to participate in trials. And that is a piece we really need to be putting the microscope on and get that right. Because if we get that, then you can have great quality care no matter where you are in Australia. And we've shown it in our little microcosm at Melanoma Institute Australia.
And one of the really important things about the Australian Comprehensive Cancer Network is that you take those areas of excellence and you lift, shift and tailor them to everywhere else. So learning from each other across the country so that everybody improves.
And the continuity of care for someone in Broome, for someone, I've treated people out in Burke, is that advanced care nursing.
I thank you both very much for your support of rare cancers in your work. And I thank you both for being leaders with great ambition and for supporting the moonshot. And I take what you said on board, Georgina, with us continuing these conversations together and in collaboration to make sure that the dial continues to shift in the right direction. Thank you both very much for your leadership. Thank you.
Thank you.